Hi everyone, and welcome to the MDH Stroke Program Monthly Webinar Series. This is Nikki Anderson, the Stroke System Nurse Specialist. Today we are so very excited to bring you a topic that was specifically chosen for you as our audience, post-alteplase care and management, which will be presented by Melissa Freese. Before I turn things over to Melissa, I do just have a few things I'd like to go over. Many of you have spent countless hours planning and prepping for COVID-19 in your communities. A few weeks ago, we encouraged you to connect with your telestroke partners to seek guidance on preparing to admit stable IV alteplase patients and what this may look like at your facility. I know many of you immediately connected with your transferring centers and spoke sites to begin planning, and we thank you for that. Truly, challenges are what make life interesting, and overcoming them is what makes them meaningful. You are all doing amazing work, and we want to thank you for your continued dedication to your stroke programs during this challenging time. It's a good thing when we have an objective slide because that typically means we are offering contact hours. At the completion of the webinar today, we will place a link in the chat box for the survey. When you complete the survey, you will also receive your contact hour certificate. As a reminder, the link will also be in the follow-up email. And given the unique working situations that are happening currently, we will also include the link to the survey in the description text located under the video in YouTube. We'll keep the survey open for a while to give you plenty of time for viewing. The objectives for today are to state 2 websites that are available for downloading free stroke public awareness materials, understand the potential complications post-IV alteplase, and identify assessment requirements to identify potential complications and reduce the risk of complication. Your lines were muted upon entry, and to ask a question during the presentation, please use the chat box. At the end of the presentation, we will answer questions as time allows. Otherwise, we can follow up with questions that have come in. All right, a quick update from our stroke program. Al sent his monthly message just last week, which included an all-inclusive stroke update. Please reach out to us with your questions, comments, and concerns. We are here for you, and please continue to pay attention to our stroke program webpage. Any updates or developments for our program will be posted here. So May is right around the corner and continues to be Stroke Awareness Month. We've been told across the nation and here in Minnesota that stroke volumes are down. Stroke messaging to the general public continues to be important, if not now, more than ever. And we encourage you all to promote the importance of recognizing the signs and symptoms of stroke in your community. On our website, we do have a dedicated section to public awareness known as our Every Second Counts Stroke Awareness Campaign. To access the toolkit and images, go to the website and click the link that says Be Fast Stroke Communications Toolkit. Then, using the link provided in the toolkit or online, head to the Every Second Counts Stroke Awareness order form to request the graphic images directly. And many of you know Brad and Maruva, the Genentech representatives for our state and its borders. They kindly ask that we remind you that Genentech continues to offer BFAST materials at no charge. These tools are great to have available, especially for the upcoming Stroke Awareness Month. And simply follow the steps on this slide and feel free to order multiple items for additional quantities. They're hoping you can take advantage of these resources not only for May, but throughout the entire year. With that, I am delighted to introduce our guest speaker today. Melissa has 20 years of experience in neuroscience nursing in direct and indirect patient care roles. She has worked as a staff nurse, charge nurse, NPCU trained, and as the neuro and stroke case manager. In 2010, she was hired full-time to work on the development of the stroke program, and in 2011, the St. Cloud Hospital achieved primary stroke center certification. She's continued to work on improving stroke care and expanding services provided in central Minnesota. In 2018, the hospital was awarded as a comprehensive stroke center. Throughout this time, Melissa was also instrumental in developing the robust telestroke network. Melissa's dedication to improving stroke care extends beyond central Minnesota and has served on several statewide committees to help develop statewide stroke education, the stroke system of care, and acute stroke designation. She is a current member of the ASA and AANN And in 2006, she was certified as a certified neuroscience registered nurse and was certified as a stroke certified registered nurse in 2016. With that, please welcome Melissa. Thank you.
All right. Thank you, everyone, for joining today, and thank you for the introduction. You already saw the objectives. I have no disclosures, but it's an honor to be able to present to you today the care of the alteplase patient, post-alteplase patient. And just want you to, keep in mind for those of the hospitals that are considering keeping your stable alteplase patients in your ER where you haven't previously done this before. A lot of, nurses do also work on the inpatient side and that also work on the ER side. So it's kind of just continuing that care of that patient that you provided for in the ER and just continuing that close monitoring on the inpatient side. So I have included some case studies to kind of help set the stage for the presentation and the discussion. So we have an 82-year-old male that arrived at an outside hospital at 4:13 via EMS as a code stroke. The patient had confusion, right facial droop, slurred speech, and the balance was off. Had a history of stroke risk factors. Blood pressure was 165/95, so a little borderline. Last time known well was 330. The CT came back negative or no bleed, and labs were normal. So at this point, we are thinking we are going to go ahead and this patient would be a candidate for alteplase. So the focus of this presentation is not on the details of the inclusion-exclusion criteria for alteplase. However, if we carefully select patients, we will reduce their risk of complications. We all know the contraindication list is very extensive, but when you are initially calling a code stroke based on the last time known well, you can begin collecting information in broad categories of contraindications and then hone in if there's any concerns. The entire list, of exclusions and especially those related to rare occurrences should be discussed with the stroke expert. So the first thing we look at is the time window and the blood pressure parameter. We know before alteplase is given, we need to keep that blood pressure, have that blood pressure below 185/110. And then we want to know the anticoagulation use, if they're on any anticoagulation, and if they are, what are their INRs, and if they have any bleeding disorders that we are aware of, we'd want to know their platelets and that before administering alteplase. We'd ask the patient if they've had any active or recent bleeding, and such as ICHs, subarachnoids, internal bleeding, GI/GU bleeding, and then if the patient indicates they do have that, they would hone in a little bit more of that time frame. We'd ask the patient if they've had any recent traumas or major surgeries, heart attacks, aneurysm, tumors, AVMs, things like that. And then looking at the CT scan, if there is greater than 1/3 of the cerebral hemisphere showing those early signs of ischemia. So, I went the wrong way, sorry about that. So our patient did not have any contraindications, and they were administered alteplase at 17:47 and left the outside hospital at 1800. So really quick transfer out. NIH stroke scale was 11 at that time. During transport, the blood pressure was borderline. We do encourage and we want to make sure that EMS is continuing to monitor that en route and providing medications if the blood pressure becomes elevated. The patient was admitted directly to the ICU, and as you can see, the blood pressure was, again, borderline 188/95. After alteplase, our parameters are to be less than 180/105. So the patient had the right upper extremity, lower extremity strength 4 out of 5, disorientated speech was clear, fluent, no visual deficits, no facial palsies. So I want to just start talking first about the vital signs. And the highest risk for hemorrhagic transformation is within those first couple hours after the infusions. But patients can remain at risk for hemorrhagic transformations up to 24 hours and as far out as 36 hours, but that is less common. There is very little literature available on how frequently we should do neurovital signs after a patient, a general stroke patient, but there's pretty clear guidelines after the alteplase patient. And you're all very familiar, I'm sure, with these frequency of vital signs, and the increased frequency in the first couple of hours is because of that increased risk for hemorrhagic transformation. And watching that blood pressure to reduce that risk. So at minimum, we should be checking the blood pressure, heart rate, respirations, and oxygen. The temperature should be monitored at least every 4 hours to make sure the patient does not become febrile, which can lead to poor outcomes. And the blood pressure should remain less than 180/105, as I had mentioned. Oftentimes, alteplase orders will include some type of blood pressure medication so that you can initiate those medications as soon as that blood pressure becomes above parameter. But if you do not have blood pressure medications in place when you are starting it, it would probably be a good idea to get them in place so that you do not delay treatment. So this is right from the 2019 stroke guidelines that offer suggestions of blood pressure management. If the blood pressure is greater than 180/105, labetalol IV, followed by a continuous infusion or nicardipine, and more recently, the clofidipine has been available. So I just encourage you to work with your primary and comprehensive stroke centers, work with your pharmacist, what you have available. Oftentimes we give, especially before alteplase is given, we start with a one-time dose of labetalol, and if we're not able to keep that blood pressure down, we follow up with those infusions. So then I want to now talk about the NIH stroke scale and the neuro assessments that we do. So we're really used to doing that baseline NIH stroke scale. And after alteplase, it should be done 2 hours post-treatment and then every 24 hours after that. That can be done by the nurse or your provider as long as we can see a trend of that NIH stroke scale. And for the neuro assessments, again, what exactly that would entail is kind of dependent on each organization. So I would encourage you, again, to work with your primary and comprehensive stroke centers to develop a neuro assessment, but should at minimum include level of consciousness, orientation, motor, speech, motor function, strength, sensation, visual fields, gaze, pupils, and a facial palsy. Doing a Glasgow Coma scale alone is not sufficient enough to determine the patient's deficit. Remembering that a Glasgow Coma scale is a generalized consciousness assessment and does not focus on the deficits, and especially one-sided deficits. It's a general assessment. So the frequency, you are familiar with that. That is the same as the vital signs. And again, the importance of doing that on, as on time and as described here to determine any slight changes in neural status that we would need to get in contact with the stroke providers. Other assessments that should be considered while you are doing the neurovital signs is monitoring any disturbed sites. If they had IV draws, or lab draws, IV sites that catheters started, and then also your oral lingual angioedema. So when we think about the risk of hemorrhage, we kind of go back to the original NINS alteplase trial in 1995, and when that's quite a while ago, but we still use that symptomatic ICH of 6%. So when you hear the providers talking with the patients and families about their risk, that's where that 6% comes from. But the long-term outcome for the patients that received alteplase do significantly better than those that do not. Another thing to keep in mind as well, we don't always know up front if we are dealing with an ischemic stroke. We're treating it based on symptoms, the last time known well, the history. The CT scan should not be showing an ischemic stroke, otherwise we wouldn't be giving alteplase. And so sometimes we have mimics that we may be giving alteplase to, but the risk of having a hemorrhagic transformation, if it is not a stroke, is very minimal, as low as 0.5% risk of hemorrhage. Then we, a little more recent trial, but still quite, 10 years ago or 12 years ago, is the ECAS-3 trial, where they looked at the symptomatic and determined the symptomatic ICH was 2.4%. And so we're getting better at determining patients that qualify and making sure that we're giving the right treatment to the right patient, and that has decreased that risk of hemorrhage. What we're looking for in a patient that may be exhibiting signs of an intracerebral hemorrhage is that change of level of consciousness. They are starting to get a little more difficult to wake up. They're a little more sleepy. They're complaining of a headache. This can be all individual symptoms. They don't all have to be happening at once. They could just have one of these symptoms, but the headache, nausea, vomiting, their deficits they had suddenly start becoming worse, and their blood pressure is becoming elevated. Some of the late signs of if a patient is bleeding and they're developing intracranial pressure, that is not signs that we want to see. It include pupillary changes and what's known as the Cushing's triad, an elevated blood pressure, bradycardia, and respiratory. And usually in those conditions, that is indicating significant intracranial pressure and pending herniation. So we want to intervene before we get to that stage. So in our patient, we're going to go back to at 7 o'clock, he began thrashing around in bed, yelling for help, stating he cannot see and had a severe headache. Blood pressure was elevated, a CT was ordered, and the patient did have an occipital and small frontal lobe hemorrhage. The NIH stroke scale did not change much, but labetalol and nicardipine were started. And then the patient was administered 2 units of platelets, the cryoprecipitate. And for this patient, they got tranexamic acid and aminocaproic acid. Typically, you only use one of them. I'm not 100% sure what the rationale was for behind that, but typically when we are doing that, you would give one or the other. So to treat and manage that ICH, if they're exhibiting any of those symptoms, the first thing you're going to do is stop the alteplase and order that CT. And if the CT comes back with a hemorrhage, you would immediately be contacting your primary comprehensive stroke center to initiate transfer and further direction. Neurosurgery should be consulted. That can take place. Usually the stroke providers would initiate that consult if they're transferring, if you're going to be transferring the patient to the tertiary center. But depending on the location and the size of the hemorrhage, doing a hemicraniectomy and evacuating that may help prolong the and improve, may not improve the patient's neurological condition, but is more life-saving. So then we will also collect labs, and based on those labs, we will replace a fibrinogen and the platelets administration, and as I mentioned, aminocaproic acid or tranexamic acid. And on the next slide, I kind of have a little diagram of how those 2 medications work. I found this a few years ago, and it just really helped me visualize where our alteplase medications are coming in and activating the plasminogen, and then over on this side you can see on the right side the aminocaproic acid and tranexamic acid, which halts or stops that continued activation. And so with these medications, though, they're only most effective within the first couple hours after administration of alteplase, because the half-life of alteplase is pretty quick. And so after a couple hours, it just felt that these medications are not useful anymore. I also like this diagram because as you go down further on the cascade, you can see that activating the plasminogen and the plasmin is where you can see the breakdown of the fibrinogen, and that's why we also need to replace that fibrinogen. All right, so our patient did have a neurosurgery consult, didn't need any intervention at that time. CT did show the edema. They started hypertonic saline to help with the edema. The patient then just developed a lot of medical complications that wasn't related to the administration of the alteplase, and eventually did discharge to the a skilled nursing facility for rehab. So I have one more, wanted to just talk about the complications, other things to look for, and interventions that you can do. We talked about like superficial bleeding. We want to avoid those, any tube insertions, IVs, if we can avoid that, and any unnecessary lab draws. Watching for those invasive sites, those disturbed sites, and if we are noticing bleeding, apply direct pressure or pressure dressing to any compressible puncture site. We want to avoid aspirin or clopidogrel, any kind of antiplatelet, anticoagulant for the first 24 hours after the infusion. Internal bleeding can be a little bit trickier to identify: retroperitoneal, GI, GU, respiratory. This is where we want to avoid those inserting in Foley catheters within, usually we say a couple hours, NG tube placement. What we want to watch for is any tachycardia, decrease in blood pressure, pallor, or restlessness or pain, which may be indicated of a internal bleed. So quickly, the last case study I have here is a 92-year-old female arrived at 12:27 via EMS, again as a code stroke. Disconjugate gaze, blurred vision, right arm and left weakness. Last time known well was 10 o'clock. She does have a history of AFib, but was only on aspirin, so we knew that right away. And then her other risk factors, blood pressures were actually on the lower side. CT was negative and labs were normal. Alteplase was administered at 1:26. And then at 2 o'clock, shortly after that, she started developing swelling of the upper lip. Alteplase was stopped and Benadryl was administered at 2:13. So if any of you have experienced this or know where this may be leading to, what the concern is oral lingual angioedema. So this is pretty rare, about 1 to 5%, but we want to be monitoring it because it can be a complication that could be quite severe if it's not treated right away. Otherwise, it's usually pretty manageable. There is an increased correlation with patients that are on ACE inhibitors and they are receiving alteplase. Usually this occurs within the first couple minutes to a couple hours and is more common in the insulary and frontal cortex. And also, interestingly, it also occurs contralateral to the stroke, which I found that quite interesting. So what we're going to do is, when we're doing our neurovital signs, assess the tongue, lips, oral pharynx. If we're identifying these symptoms, we are going to discontinue the alteplase, administer antihistamines, steroids if needed, and monitor the airway and prepare for intubation. We want to intubate probably sooner than we would probably have for a threshold of these patients, because if we start losing that airway and this patient has received those thrombolytics, it can lead to a pretty messy intubation. So going back to our patient at 2:25, she also began having difficulty finding her words. She was only alert to self at that time and was restless. So now we were concerned that this patient may be having a head bleed as well. So a CT was done, but that was negative, thankfully. They felt maybe she was just getting a little anxious, and so they gave her some lorazepam. She also had bleeding from her lab draw at her site and bruising to her hand, and then began having some bruising and swelling to her right eye. So she was really having some complications from that, but manageable by applying pressure and just monitoring those sites. And within a few hours, the swelling was already gone. She was able to transfer to our step-down unit. The next day, the MRI showed a stroke on the left parietal lobe. And remember, I said that her swelling was on the right side. So again, that was an interesting correlation. You know, she had originally failed the swallowing valve because of that swelling, and nursing did repeat it, and the patient did pass, but they wanted speech to confirm that, and she did. She did start on the Coumadin for that AFib and discharged to a subacute for rehab with a modified Rankin of 1. So she had a pretty good outcome despite some of those complications. Those are my references that you'll have available. And then I will, at this time, turn it back to Michelle and Nikki.
Great. Thank you so much, Melissa. I really appreciate that. At this time, it looks like we do have a few minutes for questions. If you can type in your questions into the chat, that would be great. Or you are also able to press *6 to unmute your lines. Michelle or Allie, have any questions come in that you guys can see?
Hi, Nikki. Thanks for checking. No questions have come into the chat.
Okay. Well, we'll give it another minute here. If anybody has a question, please feel free to interrupt by pressing *6 or enter it into the chat. Also at this time, I just want to mention, Allie so kindly put the link to the survey in the chat box. So please remember to click on that and complete the survey so that you can receive your contact hours certificate. And for those of you listening to this recording, a link to the survey was included in the email, and you can still find it available in the description text under the video on YouTube. Well, it doesn't look like we have any questions, so we can go ahead to the next slide here. And I want to, again, thank you, Melissa, so much for the wonderful presentation today on post-alteplase care. Well done. I appreciate your time and for volunteering to do this for us and for our other hospitals. Thank you again to everyone here joining us today or for listening when you've had the opportunity. Our next webinar is planned for May 20th, and stay tuned for an invite for that. And please remember to take care of yourselves and each other. We will talk to you guys next month. Take care.